My name is Christine Schrader. Most of you may know me simply as Christine from the Ocular. I live in Southwest Florida, and I'm a 6-year survivor of stage 4 ocular melanoma. Like many of you, when I was first diagnosed, I had no idea that one could even have cancer of the eye. Forgive me, I'm working on paper instead. But initial concerns were merely cosmetic and vision related, as you know. I was very, very wrong. I've been researching our condition since 2003, when I learned that the disease might not only take my sight, it could also take my life. In 2005, the battle for my life began. I was diagnosed with liver metastasis and given 6 to 12 months to live by a melanoma specialist. That was despite having my tumor detected early, and I was a prime candidate for resection. It was this particular specialist's opinion that any treatment would only be futile and detrimental to my quality of life. Had I accepted his professional opinion, I would be dead. It's a very powerful statement, but I've heard that from almost every long-term survivor that I've ever met. The problem always originates with the opinion that nothing can be done once the metastases are discovered. I'm one of a growing number of people who disproves this negative opinion, a negative opinion that has cost far too many lives and continues to hinder desperately needed advancements. While our healthcare systems may differ, I found by communicating across the globe that we all have one challenge in common, and that's obtaining adequate care post-treatment of the primary tumor. And the first step is really to become educated about the disease, become familiar with the different treatment options available, and then make your own informed decisions. And this is where you'd normally see a neat slide about early detection, but so many of the wonderful physicians have already covered that thoroughly. There currently are no universally agreed upon systemic surveillance guidelines, and of course early detection is not a guarantee of prolonged survival, but it will provide you the best opportunity to obtain the most promising therapies. Of course, as we've already gone through, resection would offer the best response rate, and it would be your only chance of being a candidate for resection. Of course, it relies upon detecting metastasis while they are still small and isolated. And I believe somewhere in the handout there we have the schedule, which is consistent with everybody else's, the imaging schedule. Liver function tests, as we know, are inadequate to detect metastatic disease at a treatable stage, and a doctor that only offers inexpensive blood tests as a follow-up is merely offering nothing more than a false sense of security. Another long-term survivor asked that I also mention the importance of extrahepatic imaging. Her metastases were discovered not in the statistically expected liver, but rather first in the lung and later the brain. I'm very happy to inform you that currently she is free of clinical disease 8 years after stage 4 diagnosis. So while ocular melanoma has a tendency to metastasize to the liver, and statistically that is by far the most common location of first metastasis, it's also important to have periodic, most recommend annual imaging, the CT, chest, pelvis, and MRI of the brain. As you know, metastasis can occur anywhere in the body. Time will not allow me to go into the detail of all the treatments I have received. There should be my history. In addition to a friend of mine, Esther. But most of the treatments that I've had are available in the UK if disease is detected early enough. Most of them are considered experimental, and often we must be our own advocate and locate them on our own. Clinicaltrials.gov would be an excellent starting point, and most treatment facilities will list their currently available trials online. There are times when you may feel very much alone. I was helped tremendously by joining an online support group. Not only did I meet wonderful people, but it was really the only place where you could find firsthand experience from the patients and information about all the different treatment options available. I was encouraged by so many of their stories, and met a lovely woman who has been battling ocular melanoma since 1980, and she has been stage 4 since 2002. Her name is Esther, and she has also submitted some excellent suggestions, which you'll find in the handout and the non-existent slide. Ocular melanoma is a very peculiar disease, and what works for one will not necessarily work for another. Metastatic disease does not always mimic the aggressiveness of the primary disease. Just as an example, my primary tumor had many negative characteristics with a very poor prognosis, yet I've been blessed with relatively indolent metastatic disease. My plaque roommate, on the other hand, had a very small primary tumor in a statistically better location, so much so that most doctors might not even have advised her to have semi-annual imaging. Yet sadly, she passed away from metastatic uveal melanoma that was fiercely aggressive, less than 2 years post-treatment of the primary. And while advancements are being made in an attempt to identify those at greatest risk, there currently are no proven methods and no guarantees. Some, like my friend Esther, go many years before metastasis. For her, it took 22 years. Cutaneous melanoma guidelines suggest that there is no further need for scans after 5 years. However, ocular melanoma is not the same as cutaneous melanoma, and systemic surveillance needs to be a lifelong consideration. So I've included both of our histories to hopefully show the differences in different treatments and aggressiveness. Similarly, most of the current research focuses on cutaneous melanoma, simply because of the numbers. Some of these therapies might not be effective for us, and because there are the mutational differences that have been already discussed. However, there are some encouraging advancements being made, particularly in the field of immunotherapy, which theoretically could be equally effective for ocular melanoma patients. One prime example is ipilimumab, now called Yervoy. And although the data is commingled between ocular and cutaneous in the literature, response rates are not quite where we'd like to see them. I am living proof that it can be beneficial in an ocular melanoma patient. Surviving a rare cancer is not easy. I had to fight for treatments. I had to find many of them on my own, and I had to challenge the opinions of the best. But you can do this too. You must ask for the treatments that you desire to pursue. I found that some oncologists will only offer what is conveniently available to them and not necessarily what is best for the patient. You must find a doctor that is willing to work with you, perhaps one of the wonderful physicians that have taken the time to be with us today. And remember that everybody has a specialty. What might not be considered possible or even worthwhile to one may be viewed entirely differently by another. And once again, I believe my friend Esther had said it best. The following is a quote from one of our recent online postings with her permission. And she writes, "I soon realized that no one physician or researcher is familiar with all the different pioneering efforts going on, but each is an expert in his or her own area of investigation. It became, and still is, incumbent upon me to sort these out while seeking advice from these experts, to assess which is the best treatment option for me to seek next, then to find a physician who has the expertise and willingness to treat me. In this way, I have taken control of my own medical care in the area most threatening to my life." Early detection will allow you to make personal decisions that can be very difficult. Not everyone will opt for aggressive treatments, and that's fine. But I feel it's imperative for you to make the decision and not a doctor relying solely upon statistical data. We are individuals, not statistics, and with increasing numbers of patients presenting with disease earlier and a more treatable stage, the data or proof required to show that these treatments can indeed be effective and add good quality of life will only naturally follow. How are we going to find effective therapies in the adjuvant or advanced setting if the patients that present for disease already have substantial disease? This should not be a do-it-yourself disease, and what we accomplish together today will only be beneficial to others in the future. It's been an absolute pleasure to be here today. I'm so grateful to see everybody working together, the doctors and families, helping us transform uveal melanoma into a manageable condition and not a death sentence.